All right. Hello, good evening. Thanks. We are happy to be here this evening. My name is Brandy Darby. I'm the director of our Division of Surveillance and Investigation within the Office of Epidemiology at the Virginia Department of Health. I'm going to kick us off this evening with some background information and a little bit of a situation summary, and then I'll be handing over to Dr. Lori Furlano, who's our director of our Office of Epidemiology and our state epidemiologist, to talk a little bit more about human health concerns. So if we go to the next slide. And we can actually, go through to that one. As I'm sure all of us are aware, influenza viruses cause contagious illness. These viruses are categorized antigenically into 4 genera. Influenza A and B viruses can trigger seasonal global epidemics in people. Influenza C viruses cause milder human illness, and influenza D viruses mainly infect cattle and are not known to infect people. So our conversation this evening is going to focus primarily on influenza A viruses, which are the viruses responsible for avian influenza. Next slide. So this image shows the ecology of these avian influenza viruses. And so as you can see, they can be found in many different animals, including ducks, chickens, pigs, whales, horses, seals, and cats. Wild aquatic birds, notably, are the natural reservoir for these viruses. And so not specifically noted on this slide, but these viruses are divided into different subtypes based on their surface proteins, specifically the hemagglutinin and neuraminidase proteins, which we abbreviate when we talk about them as our H proteins and these N proteins when we name the virus types. And you can see on this diagram, the solid arrows represent direct transmission events that have been established between host species, whereas the dotted lines that you see represent sporadic or limited infection of subtypes where sustained transmission in the new host has not really been detected. So you can see that for people, we can certainly get influenza infections from animals, but these tend to be sporadic in nature. And the newest addition to this diagram is the solid arrow going from aquatic birds to dairy cattle. And we can go to the next slide. So avian influenza as a term, we generally use that to refer to the disease that's caused by infection with avian or bird flu viruses. As I mentioned, aquatic birds are the main natural reservoir. So that includes animals such as ducks, geese, swans, gulls, terns, and shorebirds, including storks, plovers, and sandpipers. These viruses are very contagious bird to bird, and they are shed in both respiratory and fecal secretions. We think the primary method of transmission between birds is through the fecal oral route. Importantly, these viruses are further subtyped according to their pathogenicity or their ability to cause disease, specifically in chickens in laboratory settings. So most of our avian influenza viruses are going to be of the low pathogen nature. These might cause clinical signs such as ruffled feathers and a decreased egg production, but they typically cause mild illness in chickens as compared with our highly pathogenic avian influenza A viruses, which cause significant morbidity and mortality in poultry. Next slide. So most of our avian influenza viruses are going to be of the H5 or H7 subtypes. And as I mentioned, most are going to be of the low pathogenic nature. In our wild aquatic birds, we will often see no signs of illness. The animals appear completely healthy. That said, we have seen large mortality events in wild birds in Virginia. So This virus began circulating in the United States in early 2022. And since that time, we were seeing large die-offs, mostly black vultures, but also some Canadian geese in many different parts of Virginia. And then earlier this year, we were seeing some pretty large shorebird die-offs in the Hampton Roads area. And I already mentioned that these birds tend to shed the virus both in feces and respiratory secretions. We can get to the next slide. All right, so to walk through a little bit of a timeline and a current situation, this particular strain of H5N1 was first detected in January of 2022 in the United States. And since that time, it's been circulating in North American wild birds. It's also spilled over to infect backyard poultry flocks, commercial poultry, wild terrestrial and marine mammals, as well as several domestic animal species, including dogs, cats, goats, and dairy cattle. So that's the newest member to our HPAI family. On March 25th, we had our first HPAI infections in dairy cattle in Texas and Kansas. And then on April 1st, CDC confirmed that a person in Texas tested positive for H5N1 after exposure to dairy cattle who were presumed to be infected. And on April 5th, CDC released a health advisory informing healthcare providers, state health departments, and the public of the situation. Since that time, 2 people in Michigan have also tested positive for H5N1 after exposure to dairy cattle. And to date, there's been no evidence of person-to-person transmission. Important for us here in Virginia, so far we have not seen any H5N1 detections in either people or dairy cattle. Next slide. So these numbers were our current US situation as of June 3rd, 2024. We do maintain surveillance in wild bird populations, and we've had just over 9,000 detections there since surveillance efforts began. These numbers are from 2022 forward. Notably, you can see we've had over 96 million poultry infected, which represents our largest animal health outbreak in US history. And these numbers, as of June 3rd, we had 79 infected dairy herds that were spread across 9 US states. That number as of today, I think, has gone up to 11, with Minnesota and Iowa being added to the list of impacted states. Next slide. So to go a little deeper with what we're seeing in cattle, as I mentioned, we had these first detections in March of this year in Texas and Kansas. And these cattle were showing really non-specific signs of illness, including decreased milk production and decreased feed intake. They tested negative for more common causes of these types of illnesses in cattle. And then United States Department of Agriculture National Veterinary Services Laboratory then went on and confirmed H5N1 infections in cattle after these more common causes of illness had been ruled out. Since that time, we've seen evidence of both cow-to-cow transmission and subclinical infections in cattle. A nice example of this was a situation where cattle had been shipped from an impacted herd in Texas to North Carolina and commingled with the North Carolina cattle. The North Carolina cattle appeared completely healthy. They were tested, and lo and behold, they tested positive for H5N1, even though they weren't showing any apparent illness. On April 25th, the United States Department of Agriculture announced that dairy cattle are to now receive a negative test for influenza A prior to interstate movement. And there are no federal quarantine orders around animal movement related to dairy cattle at this time. Next slide. So from the genomic epi that we're seeing from viruses that have been isolated from the cattle, we do believe that wild migratory birds are the likely source of original spillover to cattle, and that potentially could have been through cattle nosing up and having contact with dead birds, or through bird feces that's in the environment. Both are plausible sources of exposure. So far, what we're seeing from the cattle is that they are infected with the same H5N1 Eurasian lineage that we've been seeing since 2022. So we're quite familiar with this virus now, although it does keep us on our toes with the new species that it's able to infect. So far through these analyses, we have not found any changes to this virus to indicate that it would be more transmissible either to people or from one person to another. And so while we are seeing these occasional cases of spillover from animals to people, we do believe that the current risk to the public is low at this time. Next slide. A little bit on the animal health side of the response. When we have these H5N1 detections in commercial poultry, our response effort is to very quickly go in and depopulate those animals. Part of that is to shut down viral replication because we can have a large number of hosts on a very small area. But also with these birds, they get very ill. And so there are very important animal welfare concerns, and it's in the best interest of the animals that we quickly depopulate to prevent and alleviate suffering. Things are a little different with dairy cattle, and we're not at this time anticipating a need to depopulate herds. We're seeing very little to no mortality in these cattle, and they do recover and get better. Best practices include isolating sick cattle on farms away from healthy animals. United States Department of Agriculture and state ag officials are monitoring the situation in impacted states very closely. And so we don't think that we're going to need to depopulate, and there could be actually some serious potential environmental health and food security concerns if we were to depopulate large numbers of cattle. Next slide. On the food safety side of things, just in general, big picture, regardless of HPAI or not, milk from sick cattle is always discarded and does not enter our commercial food supply chain. Additionally, commercial milk is pasteurized, which not only inactivates the H5N1 virus, but also inactivates a number of other potentially dangerous organisms that exist within raw milk products. And at this time, we're not seeing any threat to our commercial milk supply, beef supply, or consumer prices. Next slide. So here's what we know from the 3 dairy farm workers that we've seen with H5N1 infections so far. All 3 of these people have had contact with infected dairy cattle. In all of these cases, the transmission seems to be going from the cows to the people. We're not seeing any evidence of person-to-person spread. Importantly, in 2 of the 3 patients, they only had eye symptoms or conjunctivitis. One of the patients, the most recently identified patient, did have some more classic upper respiratory type symptoms, including a cough but no fever, some eye discomfort and watery discharge. All patients were treated with antiviral medications and have recovered or are recovering. And so for the general public, again, that risk appears to be low at this time, although people who have contact with infected birds, livestock, including dairy cattle, raw milk products, and other potentially infected animals would be at greater risk of infection. Next slide. On the viruses that we have isolated from infected people, again, we're not seeing any changes there that would make the virus appear to be better adapted to infect people. We've not seen any markers of antiviral resistance, and the virus continues to be closely related to candidate vaccine viruses that we have available. There were some public reports in the media last week that both the United States and Europe are having some conversations about potentially vaccinating people at greater risk of exposure, including poultry and dairy workers, veterinarians, and laboratory technicians who work with these viruses. Next slide. So we have been stepping up our surveillance efforts here in Virginia to keep an eye on influenza activity. So far, we're not seeing any signs of increased flu activity through our syndromic surveillance channels, through wastewater surveillance, or through case-based surveillance data. We are requesting that laboratories increase submissions of flu A and flu B positive specimens to our state public health lab, DCLS, for further subtyping and molecular characterization, just so we can remain on heightened alert through the summer. And just a reminder for any lab partners who might be tuning in that at any time of the year, if you have some samples that are run on a multi-respiratory panel that are flu A positive, but didn't return a valid subtype result, to please also forward those specimens on to our state public health laboratory for further characterization, so we can hopefully quickly identify potential cases of novel influenza. Next slide. We've also been really active with trying to just get good health information out to Virginia farmers about this changing situation. So you can see an example of one of the new fact sheets we've developed. These are available on our public website. So we've just been trying to share information with people who are at greater risk of coming into contact with this virus and being exposed. And we've been sharing that through relationships that we have with different industry partners, including the Virginia Dairy Cattlemen's Association, our VDH milk plant inspectors, and the Virginia Poultry Federation. We're also working with partners to do a one-time distribution of PPE to farm and slaughterhouse workers here in Virginia. Next slide. And lastly, just some big messages for the public that might be applicable to some of you, and we would welcome you sharing these messages with patients that you see. We encourage people to avoid unprotected exposures to sick or dead animals, particularly those with suspected or confirmed H5N1 infection. Ideally, appropriate PPE would include a number of layers of protection, including N95 respirators, gloves, coveralls, the works. We do recognize that's not feasible and appropriate in any and every situation, but common sense best practices we hope will prevail. So if someone, for example, was to find a dead bird on their property, we encourage them to not have direct contact with that bird, and perhaps, use some gloves and a face shield and some eye protection while they use a shovel or other utensil to move and bag up that animal for disposal. And then afterwards, changing clothes, washing hands thoroughly, and just trying to use general prevention best practices. Certainly, we know that the receptors for this virus in cattle are very heavily concentrated in the mammary gland. We do see a lot of virus in the milk product, and so we are encouraging people, like we always do, to avoid eating uncooked or undercooked food or food products, particularly in this situation, raw milks and raw cheeses. And then for those who have backyard poultry in their home or have other birds that they look after and care for, we encourage those people to have separate clothing and shoes that they keep that's dedicated for use just in the animal housing areas where they go in to feed and care for those animals. And with that, I'm going to hand over to Dr. Furlano.
Thanks, Brandy. You can go to the next slide, please. I'm going to focus on some information which we hope will be helpful for healthcare providers, starting with just a general overview of human disease risk. Although avian flu A viruses usually do not infect people, there have been some rare cases of human infection, and those usually occur after direct contact with infected birds or animals or contaminated surfaces. the avian influenza virus and highly pathogenic avian influenza and viruses in general have been responsible for most human illness reported worldwide to date, including the most serious illnesses with higher mortality. Illnesses can range from very mild to severe. I'm sure you've seen some of the media reports on the cases in the United States recently. Commonly reported signs and symptoms of mild illness include eye redness, conjunctivitis, and mild flu-like upper respiratory symptoms. And less common signs and symptoms include nausea, abdominal pain, diarrhea, vomiting, and more rarely severe respiratory illness can occur, such as pneumonia, which could require hospitalization, could cause respiratory failure or death. A spread from an infected person to another person is very rare, but it can occur if the virus changes and if it gains the ability to spread more easily between people. Next slide, please. So as far as our recommendations for healthcare providers, and in the current moment, we are asking that clinicians maintain a low threshold for H5N1 testing if a patient presents with relevant symptoms and a history of exposure in the 10 days preceding their symptom onset. Next slide. So some of the relevant signs and symptoms or clinical criteria, as we call it, for avian influenza HPAI-A are listed here. We would consider a person to meet in public health to meet clinical criteria if they presented with signs and symptoms that are consistent with acute upper or lower respiratory tract infection or complications of acute respiratory illness without an identified cause. In addition, GI symptoms such as diarrhea are often reported with HPAI, H5N1 virus infection. In mild illness, you might, cough, sore throat, eye redness or discharge, such as conjunctivitis, fever, feeling feverish, rhinorrhea, fatigue, myalgia, headache. Moderate to severe illness may include shortness of breath, difficulty breathing, altered mental status or seizures, and more serious complications might include pneumonia, respiratory failure, acute respiratory distress syndrome, and other complications listed on the slide. If you can go to the next slide. Exposures that would meet public health exposure criteria may fall into 3 different categories: exposure to infected animals, exposure to an infected person, or a laboratory exposure. Exposure to the animals can include contact with potentially infected, sick, or dead birds, livestock, or other animals in that time period prior to symptom onset, 7 to 10 days typically. Contact can be defined in a number of ways, and several examples are listed on the slide. Exposure to an infected person includes close, unprotected exposure to a person who is a confirmed case, a probable case, or a symptomatic suspected case. So, for example, within a household or a healthcare facility, and public health would obviously do some investigation to determine these classifications. Laboratory exposures could include unprotected exposure to the HPAI virus in a laboratory. Next slide, please. If you do suspect, or if your patient presents with any relevant symptoms and that history of exposure in the 10 days prior to their symptom onset, we'd ask that you please notify your local health department immediately, and public health can help arrange testing with our state public health laboratory. There is a detailed document with specimen collection guidance available on our website for our state lab, DCLS. Persons with suspected H5N1 virus infection should have appropriate specimens collected as soon as possible. If the person has respiratory symptoms, an NP swab or nasopharyngeal swab, and a nasopharyngeal swab and an oropharyngeal swab combined into one viral transport media should be collected. If the person has conjunctivitis with or without respiratory symptoms, both a conjunctival swab and an NP swab should be collected. Standard contact and airborne precautions are recommended for patients that are presenting for medical care or evaluation who have an illness consistent with influenza and that recent exposure as previously described. Initiating empiric antiviral treatment as soon as possible is recommended. Do not delay treatment while awaiting lab results. The clinical benefit is greatest when antiviral treatment is administered early, especially within 48 hours of the illness onset. Next slide, please. Antivirals, primary oseltamivir, are used for treatment and chemoprophylaxis. So persons meeting both clinical and exposure criteria should start treatment with oseltamivir twice daily for 5 days as soon as possible, regardless of the time period since their symptom onset. And again, that treatment should not be delayed while waiting for lab results. Post-exposure prophylaxis is recommended for close contacts of persons with HPAI, such as household contacts. Public health would be involved if this were to come to fruition and we were considering prophylaxis of close contacts, etc. We wanted to share this information with you, and the regimen is listed on the slide. Post-exposure prophylaxis for people with exposure to HPAI virus in other scenarios, like a dairy farm, that's based on clinical judgment. And there's a number of considerations that go into that: the type of exposure, the duration of that exposure, how much time has passed, if we know the infection status of the birds or animals involved. And if it is initiated in this scenario, you should use treatment dosing for oseltamivir or zanamivir, which is 1 dose twice daily for 5 days. And this is not routinely recommended. I should also have mentioned if PPE was used without any breaches. Next slide. We just wanted to make sure you had lots of links to resources, both from VDH, but also from our partners at CDC and DCLS. There's a lot of great, really rich information about general situation, how to evaluate patients, laboratory testing procedures and guidance, treatment and chemoprophylaxis, and also some PPE information. I think that is our last slide. Well, the next slide is our last slide, but we are happy to take questions.
If you have any questions, you can go ahead and drop them in the chat. I'm seeing none. Thank you all so much for this wonderful presentation and information. As I mentioned, we did record this so we can post it to the website. And we will send out an email to all of our members within the next several days with a link to this recording. And it will also be on the MSV website as well. If you have any questions for the Virginia Department of Health team, please feel free to reach out to them or reach out to MSV and we will get you connected. Again, thank you all so much for your time, and I hope everyone has a wonderful evening.